Hi everyone, welcome to our module on transfusion medicine. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can pay us with the link that is on the screen and that's also pinned in the description. You can pay us with any of these payment methods. First of all, transfusion medicine is all about safe and appropriate use of blood products. The goal is not just to give blood, but to give the right component for the right problem. For example, if a patient has anemia, we give red blood cells. If they have clotting issues, we give them plasma. So we always need to remember modern transfusion medicine is based on component therapy, not just giving whole blood. There are four main components you need to know: packed red blood cells, platelets, fresh frozen plasma, and cryoprecipitate. Each one serves a different purpose. So a very common exam trick is that giving the wrong product. The examiners just give a wrong product in a vignette. So always match the condition with the correct component. Packed red blood cells are used when you just want to improve the oxygen delivery or restore oxygen carrying capacity. So we use them in symptomatic anemia or acute blood loss. A very important number to remember is that 1 unit of PRBC raises hemoglobin by about 1 gram per deciliter. Also, don't use our PRBCs just for volume expansion alone, because that's not the role of packed red blood cells. Platelet transfusion is used to prevent or treat bleeding due to low platelet count. So if a patient is bleeding or going for surgery and platelets are below 50,000, we just transfuse platelets. So if platelets drop below 10,000, so there's a risk of spontaneous bleeding. So this is definitely an emergency. So always think that platelets are related to primary hemostasis, which is very important for maintaining homeostasis in our body. Fresh frozen plasma contains all the clotting factors. It is used when there is a deficiency of multiple clotting factors, like in cases of liver disease or disseminated intravascular coagulation. It is also used for urgent reversal of warfarin toxicity because it works immediately, unlike vitamin K, which takes a lot of time. Now, coming to cryoprecipitate, cryoprecipitate is derived from plasma, but it is concentrated in specific factors. The most important one of all of those is fibrinogen. So, in disseminated intravascular coagulation, cryoprecipitate is the treatment of choice. Whenever there's DIC, cryoprecipitate is the treatment of choice because DIC presents with low fibrinogen and cryoprecipitate most importantly contains fibrinogen. So, it helps us in replacing fibrinogen in patients uh, suffering with DIC. It also contains factor 8 and 13 and von Willebrand factor. So it can be used in von Willebrand disease or hemophilia A if needed. So coming to ABO compatibility. So this is a must memorize concept for whenever we just transfuse red cells or when we just give PRBCs to a patient. We need to remember that O is the universal donor because it has neither A nor B antigens, whereas AB is the universal recipient because it has no antibodies. So the most acute hemolytic reactions, most of those reactions occurs due to ABO incompatibility. So this is an extremely important concept. O blood group patients, people have just anti-A and anti-B antibodies in the plasma, but they don't contain neither A or B antigens on their surface. Whereas blood group A, people have A antigen on their RBC membrane, whereas B blood group people have B antigen on their RBC membrane surface, whereas AB blood group people have antigen A and antigen B on their red blood cell surface. O is the universal donor because it doesn't have any kinds of antigens on their RBC membrane surface, whereas AB is the universal recipient because it doesn't have any kinds of anti-A, anti-B antibodies, autoantibodies in their plasma. Plasma compatibility is the reverse of RBC compatibility. Here, here AB is the universal donor because it has no antibodies, whereas O is the universal recipient. So this reversal is a common trap. So always we need to be careful with respects to ABO compatibility at the level of RBC transfusion. O is the universal donor and AB is the universal recipient. Whereas at the level of plasma compatibility, AB is the universal donor, whereas O is the universal recipient. Transfusion reactions are classified based on the timing and mechanism. So some occur immediately, like acute hemolytic anemia, acute hemolytic reactions, and anaphylactic reactions. A few others occur later, like delayed hemolytic reactions. So we always should be able to recognize each reaction from the clinical clues that are available in a question. So, acute hemolytic reaction is the most dangerous transfusion reaction of all. It is caused by ABO incompatibility. Preformed antibodies destroy transfused RBCs in acute hemolytic transfused reactions. Patients develop fever, chills, flank pain, hemoglobinuria, and can even develop disseminated intravascular coagulation. So, if this happens, transfusion must be stopped immediately because it is most dangerous and most life-threatening ever. Coming to febrile non-hemolytic reactions, these are much more benign. They take 1 to 6 hours uh, after transfusion. It occurs due to cytokines that are present in stored blood. Patients can develop fever, chills, but there's no hemolysis. So, the key point in febrile non-hemolytic reactions is that there's no hemolysis. This is actually one of the most common reactions. Anaphylactic reaction occurs in patients with IgA deficiency, and the time or course can occur in just minutes. They develop antibodies against donor IgA. So within minutes, they can develop hypotension, wheezing, urticaria, and even shock. Management is immediate. We just need to stop transfusion and start giving epinephrine in anaphylactic transfusion reactions. Now let's try to differentiate between trally and taco. So this is a very important differentiation with respect to being tested on USMLE. Trally is nothing but transfusion related acute lung injury, whereas TACO is nothing but an abbreviation of transfusion associated circulatory overload. Trally is caused by donor antibodies activating neutrophils in the lungs. So it leads to non-cardiogenic pulmonary edema and normal brain natriuretic peptide. The timing is less than 6 hours, whereas TACO, on the other hand, is simply just volume overload. In TACO, in transfusion associated circulatory overload, the brain natriuretic peptide is elevated, and this improves with diuretics and this responds to diuretics. So that's the key point that we need to remember with respects to transfusion associated circulatory overload. So the key difference between Trally and TACO is that one is an immune reaction, whereas the other is a fluid overload. Delayed hemolytic reactions occur days to weeks after transfusion, 1 to 2 weeks after transfusion. It's due to an anamnestic response, immune response against minor RBC antigens like KIDD and rhesus antigens. So, symptoms are mild fever, jaundice, and a drop in the hemoglobin level. This is less severe than acute hemolysis. So that's a key point to remember with respects to delayed hemolytic reaction. This delayed hemolytic reaction is comparatively less severe than acute hemolytic reactions. There are a few other additional complications to remember. So, citrate toxicity can cause hypocalcemia because citrate binds calcium. So, whenever there is an overload or poisoning or toxicity with citrate, the citrate can just bind with calcium and lead to reduced calcium availability in the serum, which can present with features of hypocalcemia. Hyperkalemia can occur due to potassium leakage from stored blood or stored red blood cells. Repeated transfusions can lead to iron overload. So this iron overload can be treated with iron chelating agents like deferoxamine and desaferase. And massive transfusion can cause dilutional coagulopathy, hypothermia, and hypocalcemia. This lecture series is provided free and is on an open access platform like YouTube. So the only support I would expect is just you people help with a subscription on YouTube. This series is actually designed with a motto where students or people like me can just buy themselves some time to just sit down, read their book with an active mind and solve questions rather than just watching endless lectures that are available out there. So this series is designed with a motto that we just understand what's actually tested and what needs to be studied with respects to a special emphasis with regards to exam. So I hope this is helping you. I'll be right back on the next video on white blood cell disorders. Before that, I would like to request all of you to subscribe and keep waiting for the upcoming lectures. Thank you so much. Bye.